Hello, everybody. Good morning and welcome. This is a webinar on innovative diagnostics and accurate diagnosis. This is the European Week Against Cancer 2024, and as part of their input into this, the Cancer Patients Europe is organising a series of webinars. There's one each day on a different thematic focus related to cancer. My name is Tamsin Rose, and I have the great pleasure of being the moderator for this series of webinars. Let me just give you a few practical elements before we start. We invite you to use the hashtag EWAC 2024, that's European Week Against Cancer, EWAC 2024. And that will help us contribute to the conversation and the momentum around cancer this week. This webinar is being recorded and it will be made available to you to rewatch and to share with your colleagues on the Cancer Patients Europe YouTube channel. So that's the place to go and watch this and all of the webinars in this series. We have a fantastic series of speakers for you this morning, but we also rely on you to help make this webinar interesting. So there will be an opportunity for you to ask questions, and the Q&A function is the way that you interact with us, and you'll see it on the side of your screen, and my colleagues and I will be watching the Q&A, and we've got content that we will give to our speakers a little bit later when I open the floor. So each day when we have a different webinar, we like to start with a little trivia quiz to get us all warmed up and into the mood. So yesterday, we asked everyone, where was the earliest description of cancer? And it came from ancient Egypt. Today, our question is, we want to know, where does the word cancer come from? Which language would you find it in? And you have 4 different choices, and we would like you to identify where's the origin of the word cancer? Where do we get it from? So if you could please vote, and you should see the vote on the right-hand side of your screen. And I'm just starting to see some responses coming in. Greek is a popular choice, as is Latin or Egyptian. So far, no votes for Sumerian. Perhaps that's the ancient language that we know the least. But I'm clearly getting messages that almost 70% say that the origin of the word cancer comes from the Greek language. A quarter of people think actually it might come from the Latin language. We have so many of our words also coming to us from Latin. So I think it's time we could close that poll now. And you can see that you're right, the wisdom of the crowds has again served us well today, because 3/4 of you said that the word cancer comes from the Greek language, and you are correct. It is a word that is sourced from ancient Greek. So our first written descriptions of the disease can be found in ancient Egypt, but the word cancer that we use today comes from the Greek language. So thank you for doing our wake up trivia in the morning. So let's now move ahead with the agenda that we have. We're going to be talking about diagnostics today, both innovative ones and making sure that they contribute to and are part of our approach to get accurate diagnosis. And it gives me great pleasure to introduce our first speaker, who's going to give us some context and help us to understand the landscape for diagnostics. And that's Professor Krzysztof Zielinski. He is the president of the Central European Cooperative Oncology Group, CECOG, which of course partnered with CPE to write the manifesto. Professor Zielinski, the floor is yours.
Thank you very much. Thank you for your kind introduction. Now, ladies and gentlemen, I am more or less representing, as the name CECOG indicates, Central and Southeastern Europe, where the situation is particularly, I would even say, dramatic in comparison to Western Europe. It is dramatic because we do have an enormous lack of access to both diagnostics as well as therapeutic means in general, but in certain countries in particular. So just let me mention here in this very context that we still lack in very many of these countries, and this is about 1/4 of the population of the European Union. We still lack refractory testing for malignant diseases, particularly non-small cell lung cancer. And we are still in the situation where the physician in charge has to request for testing molecular mutations or even of PD-L1 to the pathologist who does not do this in a reflective way, but only in the manner if requested to do so. Moreover, even if these tests are being done, we do have a shortage here of having tests done in their abundance relative to the availability of drugs. So, for instance, NTRK testing or even BRAF mutation testing in non-small cell lung cancer is quite restricted. And we all know that that is something which is an omittance which leads patients to not acquire and not to be led to the appropriate treatment which is available concerning targeted drugs. Now, in addition, what we are experiencing is that not all institutions, Central Southeastern Europe, are able to do all these investigations, but there are certain institutions which do one and other institutions which do other investigations, so that the tissue sample has to circulate around the country, and it takes enormously long, up to 6 or even more weeks, until the final result is available, which is, of course, quite a long time, considering that the patient could be treated within this time already with targeted drugs which are available and which are on the market and registered by the European Medicines Agency. So we do have quite a dramatic situation here, which shows a lot of repercussions to the patients, as they have to still, on one hand, wait for appropriate treatments, but on the other hand, are also led to seek for, I would say, institutions of limited reliability in order to get their results. So these institutions of, I would say, limited reliability are then generating results which have to be again retested and looked for their the validity of the results they have produced. So we do have here quite a conundrum of different difficulties, which result in the end in the non-availability of appropriate treatment in an appropriate timeline in patients with particular non-small cell lung cancer, which has become the paradigm really of targeted treatment. Having said that, we have also difficulties in other diseases, like, for instance, colon cancer, where these investigations, which would lead to targeted treatment, are not being done reflected in a reflex way at all. So what we have experienced in non-small cell lung cancer, there are certain investigations which are being done. Yes, they are being done, but not necessarily in a reflex way. But in colon cancer, this is something which is definitely not the case, and where we again have a lot of abilities to treat patients in a targeted way. So in summary, where the whole thing boils down to is that we are having real needs to ameliorate not only testing, but also then the availability of appropriate drugs built upon testing results. And that is another issue which probably would have to be discussed in a different context. But let me say this very briefly and show you the difficulties and the problems that we're having. Is that, in fact, you might be aware, of course, of this, but I'm sorry that I'm mentioning this. In fact, drugs are being registered by the European Medicines Agency in the European Union general context, but the reimbursement of the drugs is a national issue and is decided on in a national context. So again, what we have in Central and Southeastern Europe is that very many drugs are not being reimbursed, although they have been registered. And if they are reimbursed in some, I would say, problematic ways, in that restrictions are being built in, which are not part of the registration at all. So just to give you an example, for instance, in Austria, where I'm located, I'm living in Vienna, Austria, and that's where we have the CECOG head office. We do have the time from decision from the registration of the drug until the decision of reimbursement of roughly 100 days. Whereas in Central and Southeastern Europe, there are countries where this might take even 1,000 days, which is 3 years. And during this time of 1,000 days, particularly, patients are, of course, dying from the disease. Just think about HER2-positive breast cancer, where we do have wonderful drugs, in fact, in the meantime, and HER2 positive breast cancer has become a classical example for a disease where living with cancer is possible. And these patients do not have access to these drugs once resistance to antibody treatment occurs. So we have here a very problematic situation, which is not only related to diagnostics, but also very much related to treatment, and which we are fighting very much on the European scale. And I'm very happy and proud that with Antonella Cardone, we were able to set up a group which has been also present at the European Parliament, and where we're talking to members of the European Parliament to generate knowledge about this problem, because we had the impression that this is not really ubiquitously available, and that members of the European Parliament were not even aware of this problematic situation, which definitely concerns, as I said before, 1/4 of the European Union population, which of course is dramatic. Now, I understand that the European Union is not a social or health union. This is something which I appreciate or I accept as a fact. I don't appreciate it, but I accept it as a fact. There is definitely room for improvement, and I think that the new legislation and the new European Parliament, I hope, will be more insightful to understand the problems which are available in this very, very part of Europe. So thank you very much for your attention, and I hope that I just have set the ground a little bit for further discussions. Thank you.
Thank you very much. Yes, it was extremely helpful to understand the difference with some very practical and concrete examples between, East and West in terms of access and what that means for patients' lives. And in fact, in our webinar yesterday, which looked at prevention, we saw, again, huge differences with many Central and Eastern European countries having very low take-up of prevention tools like the HPV vaccine. So clearly, we can see that Europe is not one space of equality when it comes to health. So thank you very much. Let me introduce the two other people who are going to join me on this panel to help explore this issue. Welcome to Meryl Hennig, who is a patient advocate from the organization LUCE, and Francesco Florindi, who is the chair of MedTech Europe. Welcome, both of you. Now, just before I ask you a couple of questions, I have a poll for the audience that I would like to ask. Now, we heard a very passionate explanation from Professor Zielinski about the sort of pattern of access across Europe. So we're now going to ask you, the audience. We have a question that we're going to poll you on. And the question we're going to ask you is, how, in your professional personal experience, how would you rate access to innovative diagnostic tools? And you can give it 1 star if you think the experience is that it's very poor, and 5 stars if it's absolutely perfect. And obviously you can, on that range of 1 to 5 stars. So base it on your knowledge, your professional experience, your perceptions, what you have seen around you. How would you rate access to innovative diagnostic tools? So is it 1, very poor, limited; 3, well, sometimes if you're lucky, you get the right tests; or is it 5, in your experience, that access to innovative diagnostic tools is readily available, it's used all the time, and we can see that patients are benefiting from it across Europe? So thank you from that. I'm seeing some votes coming in, and so far, 1/3 of you say that it's about 2 out of 5, 33%. So the leading percent say actually it's about 3 out of 5 as reasonable access, or maybe if you're lucky, you get on a pathway and it's there. I also highlight what Professor Zielinski said, that it's not just the tools, you need to have reliable institutions running them and doing the testing. Otherwise, you have to retest. So there is an element around access. It's both the tools themselves and then the institutions that deliver them. So thank you for that, for your feedback. So clearly, about 10% of you who responded said actually only 1 out of 5, there's limited or no access on a regular basis to innovative and good quality diagnostic tools. 15% in their professional personal experience see no problem. It's regular, it's very clearly there. But a third of you, the biggest number of people, are at 3. So there is some access, but clearly also some barriers that we need to deal with. So thank you. Let's close that poll now. And I'm going to come to my panel again. Professor Zielinski, I'm just going to start with you briefly. You highlighted that we don't yet exist in a European health union, even though this current mandate has made very strong moves towards that and said that that's a clear goal. What would you like to see in the next mandate? We're about to change commissioners, we're about to change European parliamentarians in this area of access to innovative diagnostic tools. What would you like to see them do?
So we really have to catch up, and we do have key indicators which we have worked out upon for Central and Southeastern Europe. So we do have a series of key performance indicators which are available, and we have published this also in a dashboard kind of way for patients with from Central and Southeastern Europe. But you have pointed out very well that we do have a problem which is stretching not only from diagnostics and treatment, but we have a problem which stretches across the entire spectrum of treatment of malignancies. So this starts truly with prevention. And there are almost the extreme limits in the prevention, and there are almost no screening programs going on in Central and Southeastern Europe, which is a major problem, particularly when you consider that lung cancer is still the primary driver of mortality in Central and Southeastern Europe, where heavy smoking is still prevalent, and there are no or very limited possibilities available right now to look for prevention, like, for instance, using low CT scan for screening of emergence of lung cancer. Now, this starts, as I said before, with prevention. Screening develops to the basic tools of diagnostics, and and in my view, also very, very important. I'm a clinician, so I have a different access to this whole spectrum of questions. So, of course, the access to modern drugs is the issue there at all. And you know that the European Society for Medical Oncology has generated this magnitude of clinical benefit scale, which shows very clearly which drugs are of high value, which drugs are of acceptable value, of medium value, and of no value or limited value, let's say. And this would be a very, very good example how governments could adhere to the idea of reimbursing drugs, just adhering to this model of this ESMO magnitude of clinical benefit scale. And this should be replaced or should be replacing these sort of emotional, abdominal, or whatever feelings, how drugs are being registered right now or reimbursed right now. I'm just done, and this stretches over to also, I think, which would be very important, to also include Central and Southeastern countries from Europe also into clinical trials in a more intensive way, because this is, of course, the best way to get to innovative drugs.
Thank you. Francesco, let me bring you in on this because we hear so much about the digital revolution that's affecting us in health. And can you tell us, what that means in terms of diagnostics and therefore patient care?
Thank you so much, Tamsin. Very, very happy to be here. But before we start, I want to send a message of love to Antonella. Get well soon. We really, we want you connected with us. So, looking forward to, get well. Indeed, I'm very honored as well to be part of this as chair of the MedTech Europe Cancer Sector Group. I'm representing not just Thermo Fisher Scientific, but also all the other companies that are part of MedTech Europe focused on oncology. So, one thing that I wanted to highlight before, again, the whole answering the question is, this meeting could not come at a better time. Just yesterday, ESMO published their new guidelines on NGS, next generation sequencing diagnostics, which enlarge the number of cancers that should receive a routine genetic testing for diagnostic purposes. And this kind of, it's a great sign from a scientific standpoint. It shows that, again, ESMO is on top of the latest scientific development, but it also shows a little bit the inequality and the discrepancy between the scientific development, the digital revolution, as Tamsin said, and the reality of patient care. Next generation sequencing, digital pathologies, these technologies have been around for a while. They're not, while they're improving, they're getting better and better. They're not new. They've been implemented in several hospitals in Europe for decades, but they're not available to everyone else. So as a medtech sector, our objective, of course, is to keep innovating, keep producing these tools that do save lives, that are at the forefront of the fight against cancer. But indeed, there is an issue of access, which is, of course, impacting life of patients, but it's also impacting progress and innovation. So my message to the group here is that we are in the same boat. While clearly the medtech sector, we're doing our job in innovating, there is a job we can do together to go at the European level and, most importantly, at national level, to work better on access. The reason why I focus so much on access is because, again, we're trying to work also with CPE on education, on making patients aware about the possibilities, working with medical societies, of course, to raise awareness on what's coming, so that no one gets blindsided by this innovation in digital, in genomics, and in diagnostics. But education alone is not going to change the panorama at the local level. So my strong message, my real recommendation is we're open for business. We're here to help the patients community to go out and advocate when it makes sense in an evidence-based manner for an increased access, because innovation without access is not real innovation. It does not bring the right value to the patients. And so if the teams in CPE allows me, I'd love to share the ESMO guidelines, because again, very, very timely meeting, and congratulations again.
Thank you for that. And of course, as part, we'll send all the participants a follow-up email, and we'll put in it links to relevant documents, and we'd be very happy to also forward the new report that you've just highlighted there. Thank you. Meryl, let me bring you in. We've touched on it already in our first two speakers, but what are the current barriers faced by patients in getting access to accurate and innovative diagnostics?
Well, thank you very much. Well, I'm working as an ambassador for Lung Cancer Europe. So we see a lot of patients that are not having access to the right diagnostics. And because there's no, in every country, it's not available. And if it's available, it is not being reimbursed, even the diagnostic methods. So patients have to pay for it. And if you're being diagnosed with cancer, then you have a lack of information. So for a patient, it's very difficult to understand what NGS testing is and why it's important and why they should have it. So there is some kind of education that we have to do to get the citizens and the patients be more informed, that they know what to ask. We also have to educate more the healthcare professionals, because they don't always feel confident to read the NGS report and what it means for the treatment. And if there's no treatment, why should you test? That is the opinion for a lot of And so the confidence should be more by healthcare professionals, because they are the one who refer the testing, and the referral is also very different, so that the turnaround time, because before that the test results are coming back, is also sometimes in a delay. And also, if you are having progression of disease, you have to have a re-biopsy, and then and not every country is doing, and every hospital is doing that. So there's no quality label on hospitals who are doing the NGS testing and who are not doing the NGS testing. So for a patient who comes into the hospital, he has to trust the system, and that's it would be great for patients if we know which hospital is very advanced in testing and in treatment options, etc.
Thank you, Meryl. You've highlighted a couple of different things that we could maybe touch on. You highlighted some issues around, confidence. If you get a result of an NGS, let's say you've had access to it, how do you interpret it? What are you going to do with this? And therefore, if it tells you something, but then you don't have access to the specific treatment, what's the point of it? And in fact, we've had a question from the audience that we'll come to that says, well, should we tell patients about these tests if they're not able to then get access to the follow-on, which is appropriate treatment? You also highlighted that, there's questions of turnaround time, that you can have a test, but if the information doesn't come back fast enough for the clinician to do something, then also that's an issue. So we've got a number of challenges raised by it. And thank you, your questions are coming in online. So let's have a look at a couple of them. So it's we've had some questions, and this is perhaps for Professor Zielinski to reflect on. Milena's asking, what would be one priority intervention to implement in Eastern Europe that would help bridge the diagnosis gap with Western Europe? Francesco's already typed something, and he said, do the basics, increase your resources linked to prevention and early diagnosis so that it's linked to the international guidelines of how much you should spend on that. So that's Francesco's view, but Professor Zielinski, I'll come to you in a second. Meryl, we have this question, should we give information to cancer patients about new diagnostic and therapeutical tools, even if they're not available in their own country or their regions? Would we be giving false hope? And again, we've had a comment from Francesco who says, look, knowledge is power. You should know that there are tools out there, and that gives you the opportunity to ask and to push for it and achieve change. So Professor Zielinski, let me come back to you. The question is, what's the one thing we should do? The one intervention that would have a difference?
Yeah, well, this is a complicated, of course, intervention, but I would think that investment should go extremely up concerning health in Central and Southeastern Europe. And the one intervention is just adhere to the ESMO guidelines. So once you have the ESMO guidelines in every respect fulfilled, then you have the same kind of cancer care in Central and Southern Europe as you do have in Western Europe, and that's what we have to aspire to. There's one thing that I wanted to bring into this discussion, which is quite interesting. In Vienna, Austria, as I said, where I'm living, we're experiencing, as very many other countries probably do as well, we experience an avalanche of medical tourism from Central and Southern Europe, because patients realize that in Western Europe, sort of, and this is still the same kind of where we had the Iron Curtain, unfortunately. That's the difference between Western and Eastern Europe. That patients realize that in Western Europe, they get access to much better cancer care that they would get in their home countries. And as has been mentioned before, the trust in the system is such a problem. So we're experiencing this real avalanche of medical tourism, and that is something which probably needs to be fixed as well by the increase in trust that the patients get there the same kind of treatment as they would get in Western Europe, and this is only by the implementation of ESMO guidelines. I would not see another tool.
Thank you. So guidelines are key. Meryl, let me come to you, because we've got this question that's all about the patient experience. You know, should patients be made aware that there are therapeutic tools, that there are diagnostic tools that are available elsewhere, but not currently available for them? You know, what does that mean for patients? We've heard from Professor Zielinski that actually those who do know are moving with their feet to try and get access to these things. If they've got the means and the information to do it, they're moving. So Meryl, what does this mean for patients?
That they are moving. For patients, it means that they have the choice and that they have the knowledge that they could, they're in charge of their own health, and they're so they can make their decision themselves what they are going to do. And what you see is, for instance, when there's when there is an NGS testing, but there's no drugs for it available, then you can search for clinical trials, for instance, or you can, but you have to have hope as a patient, hope that there will be something available. What I now see is that a lot of patients who don't get the treatment here in Europe go to the US for treatment. So it all depends, and they have a crowdfunding, and they do the most strangest things, but we need to be more in European Union, and for us to have more access to all the to the right diagnostic, the right care, and the right treatment. So yeah.
Okay, thank you. So patients are moving, patients are reading and finding out about this stuff, and where they are sort of doing everything they can to get themselves access to these, you know, better diagnostics, and this NGS particularly highlighted there. Maybe we could pick up on this question that Zoe has sent to us about the rise of AI in cancer diagnostics, you know, and should that be dealt with at EU level or national level? You know, how do we build trust in it? How do we make sure that if we use AI to, you know, speed up interpretation of images, you know, digital pathologies, what's the potential role for it? Because it's revolutionized other sectors. Is this an area, and Francesca, maybe I'll invite you to start on this one. Can we trust it? Is it being rolled out? Will it make a big difference?
So actually, funny enough, I am right now, I am at the European Union Belgian presidency event on omics in personalized medicine. So the event is all about actually artificial intelligence. So don't trust me, but follow the event, and I'm happy to report back once it's done. My understanding is that artificial intelligence is already part of reliable solutions in healthcare. Again, I'm thinking of digital pathology, the role of imaging that has been increasing importantly in healthcare. So the way we use images to actually find out and diagnose cancer, sometimes better than doctors. As with any other tools, though, AI has its pros and cons. I'm working mostly in the space of genomics, where AI is crucial to identify new genetic targets. And I remember when genomics was still looked at with it was not trusted. People did not trust much the role of genomics. They were scared about the way the data could be used. And lo and behold, we have now a new legislation, European Health Data Space, that provides us a little bit more understanding and a little bit more structure on how to share this very sensitive data. As with every tool, regulation is key. Europe has already come up with the AI Act, so a proposal to regulate the way AI is implemented. The position of, my personal position is that for how much interesting that is, we really have to look at the technical applications and be forward-looking. So avoid the mistake we've done, for example, with GDPR, where the legislation was not as advanced as the technologies that it was trying to regulate, but look forward at the possible implementations and be bold.
Thank you. Professor Zielinski, would you like to comment on that? Do you see AI making a big difference? Will it increase the scale at which we can do some of these things? We've heard from Francesco that we've got this legislation being put in place, and that it's the development of economics is giving us new targets for drugs. But do you see this as perhaps part of the solution for Central and Eastern Europe? Might it bring down the cost to the point where we could use it?
Probably yes. I mean, we all, as we are here, cannot really judge the enormous impact that artificial intelligence will bring to medicine in general. And I think that this will revolutionize our entire access to care in general. Now, one of the options, of course, would be that we are increasing the results of radiologic investigations. So that would be a very interesting aspect. You know that there are already some kind of radiologic investigations and clinical trials going on, and already have been sort of completed, which show that with the help of artificial intelligence, you can rather quite strongly predict molecular characteristics of the tumor. So this might be really something very interesting, and this might really throw us forward in an enormous way. But this is really right now. I think it is, although it's probably imminent that this will be implemented, it's still a little bit music of the future. So let's see what happens there. I think in the meantime, we have to really look for an optimization of cancer care in Central and Southeastern Europe, and that is something which cannot be replaced by the artificial intelligence. But it is a political decision. It's a matter of making or defining priorities in your country's ambitions.
Thank you very much, and we're coming towards the end of our conversation. Maybe somebody in the chat has made the link to our conversation yesterday, and the focus of yesterday's webinar was around prevention. And we asked the audience, what would be the top thing to do to improve that? And the message came through: the top thing would be doing policy decision making and proper enforcement of that. Professor Zielinski, you've mentioned it's about invest in the health system so they have the capacity, etc. Make sure that you fund that. I'd like each of you to give me, if you can, just one sentence that you would like to give as a message in this area of diagnostic tools. What would make a difference? What would you like as a policy message to improve? So, Professor Zielinski.
I would replace the ambition of artificial intelligence by natural intelligence.
Okay. And natural meaning human intelligence.
Right.
Okay.
Right.
So trust in the ability of human networking, and to before we jump to AI, we should get the best out of what we already have, which is the ability to network, to share, to cooperate, and to collaborate. Thank you very much. Meryl, what would you like to give as your key final message?
Collaboration. And when we saw in COVID time that we could be as a real European Union, we should have the ESMO guidelines, and we have to implement them in whole Europe so that the disparities are going away. Thank you very much. Francesco.
A euro spent in the early diagnosis and in the powerful diagnostic tools multiplies its value many times, not just in the way that patients respond to treatment, but also in human misery, right? It decreases the amount of suffering, decreases the amount of problems, because we know that when we diagnose people accurately and early, we can save them. We can provide them a better treatment. So to me, the final message is really, let's ask our countries to implement the tools that already exist and work on new ones.
Thank you very much. So we had a couple of comments in the chat, particularly linked to AI, saying there are some risks there around that it might increase inequalities, and that we have to be careful that some of these large language models, it's garbage in, garbage out, and they are not reliable as a form of diagnostic, but they're clearly being accessed by people concerned about their symptoms. So there's an area of work that I think we need to pick up on around confidence building, around general information to patients. But let me close our conversation today by linking to a call to action. And as part of the follow-up email that you will get from us, you will get a link to the EU Semester Manifesto, which is a document co-authored by CECOG and Cancer Patients Europe. And it sets out both an acknowledgement of what has been achieved in this current mandate, where cancer was given such a priority. We had the Beating Cancer Plan and the Cancer Mission, and it sets out some key guideposts for the new mandate as they come in on where there's more progress to be delivered. And in that semester manifesto, there's a message that we need a clear and harmonized framework for the assessment and reimbursement of innovative diagnostic tools, ensuring improved accuracy and timely access for patients across Europe. And thank you to Professor Zielinski, to Meryl, and to Francesco for explaining to us just how different the picture is across Europe, and the growing use of knowledge to get better diagnostic tools more accurate, which allows us to have targeted treatment that's perhaps less invasive with better outcomes, but this is not yet fully available. We've just heard there's new guidelines that have been put out, and of course we need to upskill our clinicians in the latest information. Our patients also need to have access, some understanding about it, with these new tools and what possibility they offer. But we come back to this firm point that it's about the policy decisions, and that's about the next EU mandate. The decisions that the next set of commissioners and parliamentarians make will have a real impact both on our health systems and on the health of our populations and our patients. So thank you very much for joining us today. It was a really wonderful conversation. Tomorrow's session is going to be focusing on innovation in cancer treatment. So we'll be building on the messages of the first day about the importance of prevention. We touched today on diagnostics, and tomorrow we're going to be looking at innovation in treatment. Thank you very much for joining us, and goodbye.